Hi everyone, welcome to a new virtual morning report. Today we'll be holding a very special session in which we'll be testing the concept inspired by the Harvard Grand Round, the human versus machine clinical reasoning. So we will be reading a clinical case, and we will also be inputting that information into ChatGPT 4, and then we'll basically compare the clinical reasoning of our master clinician, Ravi, and ChatGPT. I hope you do have a lot of fun. So, as you know, AI is changing the landscape of medicine for the last couple of years in education and patient care. So, CP Solvers wants to be a part of that change. So, I hope you enjoy.
A great introduction, Francisco. I'm Ravi, really happy to be part of this initiative today. CP Solvers, we always try and bring new and innovative sort of ways to teach clinical reasoning and also learn from all of you about what you think about clinical reasoning and even perfect our art. So along with Ravi, I'm a big fan of clinical reasoning and also do teach clinical reasoning. And I thought this would be a pretty good pilot to initiate the use of ChatGPT in clinical reasoning. And what better way to start off on a Friday VMR with a case from Francisco. And one of my students is here, Mario. And during this week, we were sort of talking about how you, Mario. So we were talking about use of ChatGPT and how to really get students involved that are starting to learn clinical reasoning. It can be quite difficult, and I guess we use schemas if you don't have a method or a framework to approach it. But maybe ChatGPT might allow them to start learning it in solo, maybe as a pilot project. So I'm quite kind of very eager to see how it goes today, and hopefully we'll see the maximum use of ChatGPT in trying to solve an unknown clinical case. Over to you, Ravi.
Yeah, y'all. All I'm thinking right now is Reza, where are you? Prof Rez, he's in Japan and unfortunately is probably snoring so loud. I'm kidding. He actually does not snore, Prof Rez. I can personally attest to that. Yeah, it's gonna be a tough one without Prof Rez. But actually, as Ravi and Francisco emphasized, we really hope that this is a beginning of us recognizing the sheer power of ChatGPT. And like I said to folks in the CP Solvers chat, there's only one winner here, and the winner is always going to be ChatGPT in the future. And that's the goal, right? Is to be able to realize and leverage the power of artificial intelligence to help our patients, and what AI can do to support us and to help us be better for our patients is monumental. Instead of thinking of this as human versus machine, is to be like, how can we arm the machine to best work with said human? Though today, that's definitely not the goal. The goal is to crush ChatGPT. I'm kidding. We're going to try to make this as fun and as engaging as possible, and really think about this in two ways. Like, how can we actually better train ChatGPT or AI, but also how can we leverage it to learn from us? And I'm really grateful for the folks at Harvard Grand Rounds, including Dan Restrepo, who is a fan favorite amongst many here, and Adam Rodman, and actually many people that we know with who have really been foundational in their use of ChatGPT and clinical reasoning. And we're excited to learn from that and to use it in our space and really to spread that wisdom to you all as we embark on this new dimension of CP Solvers. And I couldn't think of somebody more symbolic to do that than Ravi, who has been a powerhouse in VMR, and equally important and symbolic is Francisco's leading us our first case. He's one of our newest team members and has a ridiculously strong passion for medicine, and clearly has a great pulse for things coming. So thank you to you both for putting this together, and apologies in advance to Ricardo, who's scribing, to the frequent screen sharing that's going to be happening, and apologies to Hugh Ting. I don't know what you're going to do for teaching points. Are you going to pick the ones that I narrate, or ChatGPT, or whatnot? We'll see. It'll be an interesting exercise, but it can't go wrong because the only goal is to have fun. But with that said, I'll pass the mic to Francisco and Ravi to take it away.
All right, so I think you can screen share the whiteboards, and I'll start reading the first aliquot. This case was given to me by Ravi, and I'm very thankful for his support, not only in putting this ChatGPT VMR, but also with the clinical case. So let's get started and have fun. So I'll read exactly what, and then the case, and then we'll input it in ChatGPT afterwards. So starting off, the first aliquot. So we have a 37-year-old Hispanic female from Honduras with no past medical history. She presented to the emergency departments with 2 weeks history of rash, reddish discoloration of the eyes, fever, and generalized severe myalgias. 2 weeks ago, her symptoms started with fever, chills, and generalized myalgias. A few days later, she had bilateral red eyes, which were itchy and painful with movement, without any discharge. No visual changes or disturbances. 1 week ago, she noticed a very painful area on her right forearm that started off as a small area but increased in size. The rash was red, raised, vesicular, and extremely painful. It spread to the dorsum of her right hand as well as left hand and right shoulder. She was diagnosed with shingles and started on acyclovir, gabapentin, and oxycodone for pain. There was mild improvement on the rash, but no improvement in the eyes.
Well, I'm still chugging yogurt because that's a Friday tradition, y'all, but I think this case is very intriguing. And we have 3 dimensions to track. First is this overt evidence of systemic inflammation with fever. And then the second layer is the fact that overt evidence of general inflammation with fever and myalgias, and then the rash in the eyes. Now, you ask yourself, like, what is going to help us make progress more? Is it the rash or the eyes? And in this case, I would make the argument that it is actually the eyes, because the rash itself, without visualizing it, helps us restrict our ability to make progress, but the eyes not so much. Whenever you have a red eye, you have to do the exact same thing that you do with red skin, which is how deep is the process? Is it on the surface like cellulitis, or is it deeper within like uveitis, scleritis, acute angle closure glaucoma, so on and so forth? And when you have bilateral eye redness without discharge, that is a big red flag that the inflammation is deeper. How do we know that? If the inflammation were more at the surface, then what would happen is that there would be a lot of discharge in proportion to the eye redness. So the lack of discharge makes it much more likely that we're dealing with either a corneal issue, a uveal issue, or a scleral issue. Of course, this could be acute angle closure glaucoma, but the absence of pain makes that a little bit less likely. So we're down to saying, is this cornea, uvea, or sclera? And only the exam will be able to help us figure that out. But scleritis is usually accompanied by a significant amount of headache or periorbital pain. Keratitis or corneal disease is also similar in that it is often accompanied by either photophobia or a lot of ocular pain. So bilateral, relatively painless red eye with alarm features, to me, has me wondering if this person has actually has uveitis, but that will be confirmed on exam. What is the general approach to the rash? The first approach to rash is to try to say, is this a rash with alarm symptoms or not? And the answer here is yes. And the most productive way of moving the case forward with rash with alarm symptoms is to study the accompanying features, hence the eye conversation, basically. Could this be shingles? Yes, it certainly could be. Ocular complications of shingles are very well described, but again, we'd really have to pay close attention to the nature of the rash. So I think what's going to be really helpful in terms of making progress is understanding the nature of the ocular issue, visualizing the rash and trying to characterize it as vesicular, nodular, purpuric, and getting a sense, an inventory of the visceral organs that are affected. In a subacute inflammatory disease process, knowing the immune status of the patient is paramount. So that'll be really, really important. But I think for me, I'm most interested in knowing what the eyes represent, and that'll be a big filter to make progress in the future. All right, time for my wiser friend, ChatGPT. So I'll pass the mic to you guys. See what it comes up with.
Okay, so to set the stage with ChatGPT, I just have to make sure, okay, if you can hear me. So we've had to put in a statement to specify that ChatGPT is engaging in a clinical reasoning case discussion. And so this introductory sort of message is placed in to ask it to think like a clinical reasoning specialist. There is another, actually, Mario helped me figure out, there's another setting here where these three dots are to enter in all the data that you want it to consider in making the differential. So I have not pasted the aliquot in or had it introduced to this case yet, but we cut and paste it into the box and we'll see what kind of problem representation ChatGPT comes up with, differential diagnosis with justification and probability of each differential diagnosis, and any diagnostic testing that ChatGPT recommends. So we'll see what it has to say. Right. So interestingly, a problem representation is a 37-year-old Hispanic female from Honduras with no significant past medical history, presents with 2-week history of fever, myalgias, reddish discoloration of the eyes, and a painful rash. The rash initially began on the right forearm, diagnosed as shingles, but has not improved with treatment, and the eye symptoms persist. So the number one differential that ChatGPT is coming up with is VZV ophthalmicus infection. And then number 2, dengue fever, 30% probability, HSV keratitis, and then toxic shock syndrome. And it's recommending a PCR for VZV, kind of premature at this stage to maybe go in on the diagnostic testing, but just interesting to see what it has to say. So, Ravi, any input on what do you think ChatGPT is helping you hone in on what the problem is?
Yeah, I think it's really powerful to see that it added what I didn't think about, which is a very morbid possibility, and one that you should think about pretty early with rash and conjunctival injection, which is toxic shock syndrome. The others crossed my mind, but I didn't say them out loud. But the fourth one, it did not, and that's a really, really cool lesson. I do think it's interesting that in my reflex opinion, and I'll reflect on this first, I'll just share my raw thoughts. It seems to be underweighing the time course, because the longer that the disease process pans out, the lower and lower viral processes take bigger stage. And for me, comparing my honest thoughts to what ChatGPT is saying, I kind of skipped over, like, I didn't say it out loud, but I skipped over in my subconscious mind a prominent consideration for viral, because it's been 2 weeks. And so we'll see if that turns out to be prominent or not. But I was not going viral as strongly as ChatGPT, because I strongly put a lot of weight in the fact that this is 2 weeks and still getting worse. Cool. All right. Why don't we get more information? By the way, I'm totally cheating because ChatGPT is going alone, and I get the benefit of ChatGPT going forward. So this is a very, very unfair competition. But yeah, Francisco, mic to you, my friend.
Yeah, very, very nice discussion. I also wonder how much ChatGPT is holding to the vesicular nature of the rash. But we will have some pictures later on, and I think they will provide some good insights. So moving on to the second aliquot, in terms of the review of systems, the patient had fever and chills but denied weight loss. High redness was noted and pain was elicited with extraocular movement. There was no discharge or visual changes. She denied hearing loss, otorrhea, and ear pain. She did mention having had a sore throat more than 2 weeks ago. There was no cough, shortness of breath, or wheezing. She also denied gastrointestinal symptoms, abdominal pain, vomiting, heartburn, urinary frequency. She denied hematuria, dysuria, headaches, confusion, dysarthria, easy bruising, easy bleeding, or swollen glands. She mentioned having severe generalized myalgias that made her unable to walk, and arthralgias in both ankles, as also as the previously described rash. She has no past medical history, no home meds, no family history, no allergies. She moved to the United States from Honduras 2 years ago. She's sexually active with one partner or boyfriend. She has no STIs or herpes simplex infection, no vaginal discharge or rash in the past, no history of IV drug abuse, alcohol, or smoking, no pet or exposure to animals, no recent travels. She works in a restaurant with no exposure to any detergent soaps. In terms of vital signs, her temperature is 37.7 degrees Celsius. Her pulse rate is 113 beats per minute. Her blood pressure is 110/80. Respiratory rate is 17 per minute, and the O2 is 100% on room air. Okay, Ravi, what are your thoughts?
Yeah, no, I think that there's a couple of other things that we've seen now, which is I missed the fact that she's having pain with eye movement. And I think the pain with eye movement is very, very intriguing. And I think we think of that as a finding of optic neuritis, which wouldn't be explanatory for the eye redness. So I think you might have to think about something else. And of the things that are most painful, sclera, cornea, or uvea, I think scleritis is usually the most painful. And so now I'm just going back and forth between what's the cause of her eye redness and pain. Is it uveitis or scleritis? And we'll be able to tell for sure on the exam. But the pain is much more consistent with scleritis. And if we're really struck by it, we might go down that way. I'll explain later why that's relevant, but I think that distinction is going to be key. We're also now getting a prominent arthritic component to this condition. So not only does he have eye issues, and not only does he have skin issues, she also has joint issues. And we now see that she probably has a visceral imprint to this disease process because she's tachycardic. So I'm really curious to see, is there a cardiopulmonary signature, or is this actually a reflection of the amount of pain that she's in? I think the fact that she's sexually active means that we have to think about HIV, and means we also have to think about syphilis, which is notorious for causing a skin eye syndrome. But I continue to be impressed, most pressingly, by how inflamed she is, how long she's been inflamed for, and which is why I wouldn't do this in real life. But if I'm literally putting on what do I think the answer is, I think it's too long to be virus. Just too long, too devastating, too severe to be a viral process. It's interesting to think, well, what could the sore throat symbolize that she had and now is gone? And that opens up a whole slew of post sore throat syndromes. The most morbid of which would be strep related toxic shock syndrome, but also a whole variety of post-infectious phenomenon from group A strep, like rheumatic fever, scarlet fever. There are many, many of them. Could be reactive arthritis too, but again, probably a little bit too hectic for that. My mind is starting to go a lot more into the autoimmune realm. And this is simply because we're kind of discussing DDXs with ChatGPT, but things like Still's disease, even Kawasaki's disease start to cross my mind. So if I were to really prioritize, unlike what we normally do in VMR, what category is becoming louder and louder and louder, it's autoimmune. Why? The duration of symptoms, the uveal and scleral involvement, both are more prominently autoimmune, and then the joint stuff. What are plausible and no-miss infections? I think the plausible and no miss infections are the usual viral diseases with this patient's epidemiological profile. But if strictly matched with the illness script, the no miss infections are the ones that reliably cause this degree of ocular discomfort, of which there are only a few: HIV, syphilis, TB, and Bartonella. So I'm very, very strongly in the world of autoimmune, unless the exposure to DB is of significance, given her background, and her sexual history is of significance. Yeah, very, very intrigued to get more information, but to also hear where ChatGPT went with this.
Yeah, let's see what ChatGPT has to bring to the table, Ravi.
Okay, so putting in the next aliquot. So the problem representation now that ChatGPT, including this second aliquot, has produced: a 37-year-old Hispanic female from Honduras with no significant medical history continues to experience symptoms including fever, eye redness, myalgias, arthralgias, and a vesicular rash. She denies weight loss, but mentions a recent sore throat and severe generalized myalgia. So the differential diagnosis still ChatGPT is maintaining VZV ophthalmicus, 40% probability, likely because of the persisting eye symptoms. The diagnosis could involve complications of VZV ophthalmicus infection, such as ocular inflammation or viral spread. The next one, rheumatic fever, as Rabi had mentioned, and then SLE is now in the picture, 20% probability, and streptococcus again is being mentioned. So for diagnostic testing, CBC rheumatoid factor ANA is new versus what ChatGPT did think about in the initial aliquot. Repeat the PCR test for VZV, throat swab for group A strep, and a EKG for any cardiac involvement. So I'll turn it back to Robbie to ponder over this.
Well, this thing is so smart. I mean, look at it. It's also heading in the autoimmune and post-infectious space. I think it's interesting to see its a hang up, which is, I think, what Francisco identified as like really latching onto that word vesicular. And I think we know that it's reinforcing something that I think has been said about AI, is if you put garbage in, garbage out. And I think we know that that the term vesicular is so loosely applied. And if you've ever struggled with calling derm and not knowing what to say, you know that like words don't capture what the rash is like in many, many instances. And so it really seems to be locking into this word vesicular which is as a computer, it probably doesn't have in it the idea that like when a clinician says vesicular, it may not be accurate. And I think that is so powerful. I'm really curious if we could hypothetically run this case and just remove that one word, what it would prioritize. I bet it would be very different. But you can see its brilliance here. It's going much more to autoimmune, but you can see also, I think, where its handicap is. Any other thoughts you guys have before we move on?
Yeah, actually, Ravi, I would like to ask you, how much do you value these percentages? And do you also without unintentionally, do you also in your mind come up with those probabilities, or
Yeah.
how's your approach? How these could complement our teaching, these probabilities?
Yeah, I think these probabilities are probably an artifact of the CPC exercise and not what people do in real life. Because what I'm actually doing probabilities for is not the diagnosis right now. What I'm trying to do a probability for is it scleritis, uveitis, or keratitis? That's what my probability list for. So I'm trying to make probabilities for not what the answer is. What I'm trying to make probabilities for right now is what the problem is. And you can see in the language that ChatGPT is using, this is very imprecise language. Ocular inflammation. It actually, the thing that will help a lot is, what is this ocular inflammation? And you can see that it's also using the term rash and joint pain. But it'll be really helpful to be like, is this a nodular, focal nodular rash? Is this a purpuric rash? So what is my mind doing? My mind is not making probabilities for the DX. It's trying to make probabilities for what will this turn out to be. Will this be a 37-year-old woman with a uveitis and a diffuse nodular rash? Will it be a 37 with scleritis and a purpuric rash? That's what I'm trying to figure out. Where will she go? And so that's where the pain with eye movements was the most powerful thing you said for me. And Yeah, so weighted probability of the problem, not weighted probability of the answer. That answer your question?
That is a very interesting teaching point. I loved it. And looking at the chat, I can see that people are rooting for you. They're saying that you are
Oh,
winning.
that's awesome. I'll have to look at the chat at the end because there's
So,
cognitively very overstimulated now with all this information. So thank you all for rooting for me. I appreciate
you're having a lot of support. So
it.
yeah, now I'll read the physical exam, and we'll also show some pictures. Unfortunately, ChatGPT doesn't have the capability of looking at pictures, but we made some.
Don't worry, I can barely interpret skin rashes either. So I think we're on the same page.
On the same level, okay. Yeah, but we made short descriptions which we'll input into
Okay.
ChatGPT. So I think that will help. Okay, so for the third aliquot, on physical examination, the patient was alert and oriented, but in moderate distress. Her eyes had bilateral red sclera with raised vessels, as well as pain with movement on extraocular movements. Lungs were clear to auscultation, breath sounds were equal, and chest wall expansion was symmetric. Cardiovascular-wise, there was a normal heart rate, regular rhythm, no murmurs or gallops. Pulses were equal in all extremities. Peripheral perfusion was normal, and there was no edema. Ankle joints were painful on active and passive movements, and on neuro exam there were no changes, no focal deficits, cranial nerves were intact, and deep tendon reflexes were also normal. So now I'm going. Should I share my screen? Do you want to share yours, Ravi? How do you prefer? I can.
Let me see.
I have
Okay,
this.
I can share. Okay, because I want to make sure I don't have a label on it.
Oh, okay. So let me share
Yeah.
it.
You want to share it? Okay.
Yeah, I will. I will. Okay. So you can see the slide.
Yes.
Okay. So Rabi, what do you think?
Wow, this is very intriguing. I think that you can see that the eyes are very, very concerning. It's panel C. You see that the injection is perilimbic. It's right around the limbus, and it's in sync with the scleral vessels, and there's no discharge at all. You don't see anything plugging the lacrimal ducts. That's very, very concerning for scleritis. I think that the rash is interesting. It's definitely not vesicular. Um, I can't, so on the arm, there appears to be, it's almost nodular, discrete nodules. They seem to be pretty raised. Um, and I'm trying to, so panel A is like discrete nodular rash on the dorsum of the hand, it seems. I
Yeah,
can't tell what body part is panel B,
it, it,
Francis?
it it's a right forearm. So it's a erythematous plaque, the right forearm. So we actually described the A as multiple boggy indurating erythematous plaques on the dorsal aspect of the left hand. The B, we described it, and this is what we are inputting into ChatGPT. Large indurated erythematous plaque on the right forearm with overlying desquamation. So you described it, the scleritis, and then on the D panel is the upper back. So small erythematous plaque with scale overlaying the patient's upper back.
That was very, very interesting. Yeah, I think that the place that I'm much more comfortable with is to really sort of share a reflection on scleritis, which the vast majority of patients with scleritis represent an isolated ocular disease of the sclera without systemic involvement. That's about 40%. But in patients who have systemic diseases, the vast majority of them have an autoimmune condition. And that autoimmune condition is usually a vasculitis, with polyarteritis nodosa and granulomatous polyangiitis, GPA, being the leading causes. There are infectious mimickers, and I think we already infectious causes. We already talked about them. Those are TB, syphilis, and HIV. And what I'm struggling with is to reconcile what explains this rash along with the scleritis. And for me, that's my like friction and growth zone, honestly. Because the plaque and the scale are certainly very evocative of this families of spondyloarthropathies that can cause a rash, with the notorious one being psoriasis. So now I'm kind of pressing the brakes and saying, I know that this family of rashes, namely evocative of psoriatic type diseases, have ocular manifestations, and those ocular manifestations are usually uveitis. So is my interpretation of the eyes incorrect? And this person has both scleritis, actually has scleritis as spillover from uveitis. And what she more has is along the lines of the spondyloarthropathies, which would have me wonder, does she have IBD? Does she have reactive arthritis? Does she have ankylosing spondylitis? So where am I at? I think the autoimmune nature of this disease has gained even more momentum by visualizing the extent of the involvement of the surface, her eyes, her joints, her skin. And there are two families of diseases that I'm toggling between. A vasculitic phenotype, which would explain scleritis much better than it does the rash, or a spondyloarthropathy phenotype, of which acute forms of IBD and reactive arthritis, which are much more compatible explanations of her rash and less compatible explanations of the word scleritis. So I think, and then of course, I think the most important infections are HIV, TB, and syphilis to exclude in this instance. Very, very intriguing case. I think next steps to understanding the problem are to understand what the nature of her visceral imprint is, of which there is decent momentum for because of her tachycardia. Because these things that we see on the screen don't account for tachycardia. And that is probably the final piece of the puzzle to really gain momentum on what the problem is. And for me now, the family of spondyloarthropathies versus the family of vasculitides are engaged in a battle. And I think the peripheral signature will help us figure out which one of them is leading, or will surprise us and make us have to completely rethink putting this case together.
Right. We'll see what ChatGPT has to say with the third aliquot, but sort of we're at the halfway point. I just want to mention one thing. Yeah, I think so far people have mentioned in the chat that ChatGPT is not able to really offer a nuanced and this back and forth thinking that you have Ravi with each iteration of this case. So much more detailed sort of journey through the case rather than just like what ChatGPT is giving, a very robotic, like this is the list of things that I am thinking about. But I have one question. What's interesting in watching VMR for many, many years and following your evolution through clinical reasoning, now you've been trying to define or pondering over the problem. Initially, the initial response with cases is, for a lot of us, is to jump into trying to find a answer. So trying to define the case, but you do spend quite a bit of time trying to figure out what is the problem. And the problem can be spread out over maybe the first 2-3 aliquots before you jump in to make a diagnosis. Any comments about that?
Yeah, I think, Ravi, all of medicine, all of teaching of medicine is all about, from medical school, learning diseases. Like, what is this disease? What is this disease? What is this disease? What is this disease? And you can find up-to-date articles on what is this disease. And ultimately, when you start to realize that you can learn about these diseases, you realize that like nobody tells you how to figure out what to understand what the problem the patient has. And so in many ways, we learn solutions, but we never learn how to come up with the problem for which these solutions are. And I think that's the major deficit, I think, in clinical reasoning and the teaching of clinical reasoning. And I think you can see that encapsulated in the brilliant data mindset of ChatGPT, which is only just coming up with solutions and is not really defining the problem. And I think it's a huge and very exciting space for us too, because it's an opportunity for us to practice first what is the problem, then is what is the answer, and also to train these artificial intelligence models to actually try to come up with that. But yeah, I think for me, I try not to propose an answer when I don't know what the problem is, unless there's a potential answer that is deadly to the patient. That's the only time I think an answer is worth thinking about before you really know what the problem is. Chest pain, radiating to both arms. I don't need to know anything else. I need to make sure this person doesn't have a heart attack or a dissection, you know? But yeah, I don't know if that answered your question. I was kind of rambling.
No, I think it perfectly answers it and just shows you the dichotomy between a person discussing a clinical reasoning case versus ChatGPT. So right now, in reflection, this is just a tool to augment your thinking, but I don't think it will provide the answer. But with each case that we're putting into ChatGPT, it will only get smarter over a period of time. So without further ado, we'll go on to the next aliquot and then see what ChatGPT has to say. So, a problem representation at this point: patient, a 37-year-old Hispanic female from Honduras, continues to exhibit distressing symptoms, including bilateral red sclera with raised vessels and pain during eye movement, painful ankle joints, and a variety of skin findings, including papillovesicular rashes, indurated plaques, and nodular episcleritis. So, ChatGPT is still maintaining that VZV ophthalmicus infection is in the running with, again, a 40% probability. Then HSV now has moved up 30% with dermatomal spread. Rheumatic fever and SLE is still being considered as in the last aliquot. And the diagnostic test, now I see a skin biopsy on one of the lesions to assess for the histopathological findings that might differentiate between VZV and other conditions. PCR test again, ophthalmology consultation, ASO titer, and ANA and anti-double-stranded antibody test. And with this new information, I'll turn it back over to Ravi to think over this new response from ChatGPT.
I'm really intrigued by this because I think for me, the biggest difference between our discussion is I really I'm using the eyes a lot, and ChatGPT seems to be using the skin a lot. And maybe it just reflects the fact that I don't feel comfortable with the skin, as you all saw. Like, I'm way more comfortable with the eyes than the skin. That for me is the biggest kind of big picture difference. I'm intrigued by the what I feel is an underweighting of the time course of like ongoing zoster and ongoing HSV for so long. That seems to be not something that would cross my mind, though I think in real life you would definitely biopsy it. But would you continue to say this is acyclovir refractory zoster and HSV? I'm not so sure many people would. But I think it might be smarter in the skin than I am, and is probably using that data more than I am. I'm also really curious to see how my reflections change outside the heat of battle, because right now it's very hard to like come up with nuanced thoughts. Did you all have any or anything that you wanted to share that strikes you between the two conversations?
I'm just thinking you're doing a phenomenal job. I think I know this case, so I can tell you're doing a splendid job of dissecting the nuanced features of this case. And you're right, it is between the skin and the eyes. So, and I think this kind of reminds me of a case we did discuss. I remember a patient from Central America that was thought to have TB and had episcleritis, and it was GPA. I think it was last year. So the discussion kind of reminds me of that as well, that we did go heavily into episcleritis.
Yeah, is it the skin or the eyes? Francisco, which one is it? Tell us more, please. Unless you have other thoughts too, please. Go ahead.
No, I think that, as Noah said here on the chat, the ChatGPT is very vulnerable to anchoring bias. And though for those who saw the Harvard Grand Rounds, the ChatGPT held to the Coogan syndrome, and until the end, it was Coogan syndrome. Yeah, like the most probable diagnosis, even though as the case unfolded, we started shifting away from that possibility. So I think that probably the first aliquot has a lot to has a big impact on how the case develops. And yeah, let's move to the next aliquot, which is the fourth, and then we'll have a fifth one. And here we have the labs. So sodium is 136, potassium 4.1, chloride 101, CO2 100, O2 101, CO2 26, BUN 12, creatinine 0.5, glucose 118, calcium 9.1, albumin 4.7, total protein 7.3, no changes in bilirubin 0.8, AST 15, ALT 22, ALP 109, CPK 22. Hemoglobin was 10, white blood cells 16,320 with 85% neutrophils, lymphocytes 8%, monocytes 6.3%, eosinophils 0.7%, MCV 68, MCH 26, platelets 424, erythrocyte sedimentation rate 101, CRP 235. In the urinalysis, we had 82 white blood cells, 12 squamous cells, leukocyte esterase and nitrates and protein were all negative. Chest X-ray was completely normal. EKG showed only sinus tachycardia. And that's it. And the next one will be the final aliquot.
Wow, the biggest finding here, Francisco, is the neutrophilic leukocytosis. And I think here it really, really makes you wonder. And here's the tension. We were making all along the argument that an infectious process is less and less likely here for the reasons we've already articulated. So the question is, what does the neutrophilic leukocytosis do to that hypothesis? Should you revisit now the idea that the person has a pyogenic bacterial infection? And I think the only one worth considering is the possibility the patient has toxic shock syndrome. But the rash is not so compatible with that, with the exception of the desquamation features that we saw earlier. So do you have to revisit toxic shock syndrome? The other important infection to consider in the circumstances is not a bacterial one, but is COVID. And this is COVID with MISA, or multi-inflammatory system A, which characteristically causes a rash, eye changes, arthritis, and often involves the GI tract with nausea, vomiting, diarrhea, and myocarditis. So I think even though you don't have any myocarditis here, you definitely want to study the possibility of that with a COVID PCR or a COVID antibody, which may be helpful here. In the world of autoimmune diseases, whenever you have arthritis and a neutrophilic leukocytosis and a rash, really the possibility of Still's disease emerges, especially in the context of a post-viral phenomenon. But this is not a clean case of Still's disease because it usually doesn't involve the eyes this prominently with scleritis or uveitis, but it can. Yeah, I think there's, in the world of autoimmune disease too, Kawasaki's is crossing my mind. The age of the patient is the biggest argument against that, but the fact that she does have mucocutaneous syndrome. She does have eye involvement. She has skin involvement with desquamation, and that would be certainly an interesting fit. And you can get actually interstitial involvement with Kawasaki's disease with the 82 white blood cells. So I think the neutrophilic leukocytosis is interesting here. What I would probably want to know most next is what her COVID status is, and see if she's COVID antibody positive or negative. But I imagine the momentum for autoimmunity is gaining weight, and the combination of pharyngitis, arthritis, rash, and a neutrophilic leukocytosis is enough to start to wonder about the possibility of adult onset Still's disease, for which a ferritin would be helpful to start to get momentum for, as would response to NSAIDs, which is another interesting tool. She is the right demographic age-wise for Still's disease, and that would make a lot of sense. A less prominent consideration would be Kawasaki's disease, and then finally the family of neutrophilic dermatoses, Sweets, Pyoderma gangrenosum, and even Sweets and Pyoderma gangrenosum. But I think the biggest argument against them is the ocular involvement and the urinary involvement, though visceral Sweets is very possible. The low MCV here is important, but it may be true and unrelated in a young, presumably premenopausal woman, as reflective of iron deficiency anemia that's unrelated to the current clinical syndrome. So this is a subacute inflammatory disease process characterized by neutrophilia. And those words are so unusual, subacute and neutrophilia. Because subacute starts to push you towards autoimmune, and usually that is not a feature. Neutrophilia is not a feature of autoimmune disease. And what are the big picture neutrophilia plus autoimmune disease spectrum? Still's disease, vasculitis, NOS, and the neutrophilic dermatoses. Which one of them explains everything elegantly? I don't think any. I think the weakest thing for Still's disease is the eye involvement. The weakest thing for the neutrophilic dermatoses is the eye involvement. And the weakest things for Kawasaki is her age and the lack of lymph node palpation. So really, really interested to see what this last aliquot will show. But I probably crossed my threshold to give this patient NSAIDs as a test for Still's, and would probably, although recognizing it's not the best fit right now, would probably put that as number one.
Okay, so we are narrowing it down nicely. Let's input it to ChatGPT.
Okay, so aliquot 4, let's see. So ChatGPT's updated problem representation. The patient's labs and additional findings reveal a complex picture. She has elevated white cell counts, particularly neutrophils and markers of inflammation, such as elevated C-reactive protein and ESR. Hemoglobin is low, and there are abnormal skin and eye findings, yet chest X-ray and EKG are normal. So now SIRS due to infection or inflammatory disorder. So very, very sort of broad overview of some of the conditions that Ravi had mentioned there. The patient's elevated white cell count, high CRP, and fever indicates an inflammatory response. Then again, atypical presentation of VZV, rheumatic fever with inflammatory skin manifestations, which Ravi had considered also. SLE is still being considered as the number 4, although 10% probability of this happening. And the diagnostic tests are continuing on with introduction of now a infectious disease specialist, a rheumatologist, and the other tests as recommended previously. I'll turn it over to Ravi to now consider this new updated ChatGPT information.
Yeah, I think you're seeing, Ravi, oh, by the way, I should just say, like, it's so cool to see how you guys are in sync. I feel like you've done this like 100 times, Francisco and Ravi. It's really cool. I can't believe this is the first time we're doing it. I'm not as present as I usually am trying to pay attention to those things, because this is such a, like, inherently, this is a very, very tough case. So I'll say it once again, Prof. Rez, where are you? Wake up, wake up. But I think what you're seeing, my reflex thought is, it goes to show you how powerful neutrophilic leukocytosis is. And you see how systemic response due to infection or inflammatory disorder just popped out of nowhere and went to 40%. The weight of neutrophilia in these cases is very, very powerful. And I think the part that ChatGPT will learn over time is to marry neutrophilia with subacute and neutrophilia with a diffuse presentation of rash, arthritis, because most neutrophilia is a localized inflammation, a pocket of pus in the right lower lobe, a lot of pus in the right kidney, like it's localized and neutrophilic. So what is neutrophilic and diffuse? That's what's really unusual, and that's the key problem in this case, is what causes the body to react in a neutrophilic way, and yet for the disease process to be scattered from literally head to toe, from eyes to skin, everywhere. And I think that's the most intriguing and narrow part of this case, is not just neutrophilia, but neutrophilia plus subacute plus diffuse. And I think that's why there's zero overlap between what I said and what ChatGPT says. Both of us could be wrong, but we'll see who's closer to the answer.
All right, so I guess we can move to the final aliquot. And here at the end, we ask ChatGPT, what is your final diagnosis? So I'm very curious about that. Actually, we don't have ferritin, but I really like that idea. But regarding the additional labs that we have, the patient was at HIV, HBV surface antigen, HBC antibody, RPR, blood cultures, gonorrhea and chlamydia, NATs, influenza A and B, CMV, IgM, monospot, they were all negative. ANAs, double-stranded DNA, rheumatoid factor, and anti-CCP were also negative. And she had an ASO antibody of 1008, and the normal values are lower than 200. So ChatGPT and Ravi GPT, what are your final diagnoses?
Okay.
I think this is, okay, yeah, go for it, Ravi. It's okay.
Right. So putting that aliquot in. So ChatGPT mentions that given the extensive evaluation, the negative results for infectious diseases, autoimmune markers, and rheumatic fever indicators, the final diagnosis could be post-streptococcal reactive arthritis. So justification is number one, the ASO antibody. The significantly elevated ASO titer indicates a previous strep infection, supporting the possibility of post-streptococcal sequelae. There's also negative infectious disease testing. So all the infectious diseases that we had considered earlier on that were important in this discussion of this case, I think, but they've all been proven to be negative. And then negative autoimmune markers, absence of ANA, double-stranded antibody, rheumatoid factor, and anti-CCP antibodies does reduce the likelihood of a autoimmune phenomena. And then the clinical picture. So the patient's symptoms, including fever, myalgias, joint pain, and skin findings, align with PSRA, which can occur as a post-streptococcal complication. However, it's crucial to consult with the rheumatologist and closely monitor the patient for any further developments, as PSRA is rare and clinical presentation can vary. Additionally, long-term management and treatment may be necessary to address the joint symptoms. So with this final diagnosis from ChatGPT, I'll turn it over to Ravi.
Guys, I gotta agree. I think that the positive streptolysin antibody really takes us into a very specific place. And now I think instead of infection versus autoimmune, you can start to say like, hey, I have documented proof that this person has had a positive a recent strep infection. So what does that mean? I'm trying to pull up a schema for you all real quick. Just give me one sec. Yeah, here you go. So I think we're here. One sec. One more person to share the screen. I think we're here. And the first question when we're trying to establish is a post-strep phenomenon, is there a visceral disease, which is really what we were waiting for? Is there evidence of a visceral imprint? Could this be glomerulonephritis or rheumatic fever? But I think the disease process is remarkably superficial. All the labs are normal. The person's EKG doesn't show any intracardiac dysfunction. The chest X-ray is normal. So this disease process is at the surface. And the question is it actually involving the joints, or is it just skin restricted? And I think I think post-strep arthritis is a very, very elegant explanation for this condition. And the couple of things that are interesting in terms of the classic presentation of reactive arthritis or post-streptococcal reactive arthritis is the rash on the hand. If I remember correctly, I haven't revisited this in a long time, but I remember the arthritis is also distal and also fixed, unlike the migratory arthritis of rheumatic fever. So at the end of the day, when you have a post-strep, when you've proven that the patient has strep and you have a post-strep arthritic problem, the question is it rheumatic fever or is it post-strep reactive arthritis? And here, the lack of visceral disease to suggest cardiac involvement, coupled with the presence of ocular manifestations, has me agreeing 100% with ChatGPT that I think this is post-streptococcal reactive arthritis. What is interesting as a whole in my knowledge is like really trying to see what is that, what was the eye manifestation after all? Was it conjunctivitis, uveitis, or scleritis? Because my understanding of post-streptococcal reactive arthritis or any reactive arthritis is that it should cause. Curious to read more about that / learn from Francisco and Ravi. So what was it?
Yeah, so basically, in the hospital, the ones responsible for this case consulted the experts in pattern recognition in skin findings, so dermatology. And dermatology, after seeing the patient, said that the skin lesions were highly suspicious for Sweet syndrome. The patient was started on 60 milligrams per day of corticosteroids with immediate improvements. She also started prednisone eye drops, and a CT of the abdomen, pelvis, and chest was ordered to exclude malignancy, which can happen associated with Sweet syndromes. And then we did proceed with a biopsy that was positive for neutrophilic dermatosis without vasculitis. So the final diagnosis is a neutrophilic dermatosis, Sweet syndrome. Yeah.
Yo, we should forget what I have to say in ChatGPT. You should just call consult derm for all your cases.
No, I got it, I
Yeah,
think.
no, did you? Nice
No, I
job,
got it.
Noah. That's awesome. That is so cool. Yeah, I think that, I think it's really, really interesting, these diagnoses that we make that are complications of post-strep. At the end of the day, I think you can lean heavily on my major weak point, which is dermatology. Like, it's not an area of strength for me. I've only seen one case of Sweet syndrome in my life, and the rash was deeply nodular and very painful. And I remember that you were saying that the patient also just noted pain. I think if you go back to this, the weightage of the joint findings and the weightage of the eye findings pushed me here. But it sounds like those were relatively unimpressive to the treating team and the dermatologists, where they were like really emphasizing the third skin manifestation here, Sweet syndrome. And I think it just goes to show you how interesting these things, because if you read more about sweets, you'll learn that it actually can involve any organ. You can actually have sweets causing devastating neurological catastrophe, causing ARDS. And the idea that somebody can have an elegant immunological response to strep and fit a category of disease, sweets or reactive arthritis or enodosum, I think is probably just reflective of our desire to put a patient in a box that we otherwise know very well. Like, we know sweets from its classic manifestation as a skin restricted disease after a URI or vaccination or pregnancy. We know reactive arthritis is a classic disease that affects the urethra, the skin, the joints, and the eyes. And for me, if I'm being transparent about what I think is going on, I think there's no doubt that this person has a neutrophilic dermatosis because you biopsied the skin and you proved that. But what is the robust explanation for the ocular findings, and what is the robust explanation for the joint findings? I'm very, very intrigued by how we fill that gap in our knowledge. I suspect that my guess would be that it's actually an overlap or like an unclear manifestation, or we just say this is sweets affecting the joints or sweet affecting the eyes. But I'm really curious, Francisco and Ravi, what your take on that was, what your take on this experience was, and yeah, those are my reflections.
I'm just going to share screen to see how ChatGPT responded to the final diagnosis. So ChatGPT, because to wrap this case up, we also need to give ChatGPT the answer so that it can also learn. So it's also learning while trying to decipher what each aliquot is. So ChatGPT is thanking us for providing the update. It appears the diagnosis has been refined based on dermatology consultation and biopsy results. And the justification, the immediate improvement with high-dose prednisone supports the diagnosis. It's typically responsive to corticosteroids, but positive biopsy for neutrophilic dermatosis and CT is ordered to exclude malignancies essential because sweets can be associated with underlying malignancies, particularly hematological malignancies. So by providing the diagnosis, I think ChatGPT will be on the lookout for another case like this in the future. I'll be intrigued to see if we feed it another case of something similar like this, what would the response, or how would the response be? So as Ravi had mentioned, garbage in, garbage out, but feeding whatever we did today. And I really appreciate Francisco for sending the aliquots in the way that you did. It made my job easier. So just cutting and pasting. And it definitely has been a pleasure to run this case with you. And this is the first time we've done it. But the eyes are very interesting. I really enjoyed the journey through this case, Ravi, with you now going through the eyes and looking at the eyes and the ocular manifestation. I kind of just Googled. So there's so many different ocular involvement or manifestations with sweets. And we always look at this nodular skin findings. But I think you really honed in. What I was particularly impressed with, because I knew the diagnosis, was the sore throat, strep being thought of early on, and then going through the neutrophil, the amount of neutrophils that were found in the differential, and how that could change this pattern recognition in the diagnosis. And then mentioning the sequelae of post-streptococcal syndromes, and you had mentioned sweets in there too. So I think it was a win for you, definitely, and this definitely augmented your dissection of this case. And I think definitely you had mentioned sweet syndrome. So Noah also added in the chat, but yeah, just going between sweet syndrome and then all the different autoimmune phenomena, I think you did a splendid job. Francisco, any reflections?
Yeah, thank you so much, Ravi. It was the pleasure was all mine being mentored by you in this case. I learned a lot. I've never seen a sweet syndrome in my practice, and actually, I think the skin findings were actually not the most typical ones from sweet. What we see in books. So yeah, it was a very challenging case, and one thing that I also take from this is how Rabi always explains us his reasoning so methodically, and actually ChatGPT is what it's called, that black box, where it may say accurate things, but we don't know what's behind all the neural networks that are really not understood. So that's something that we have to consider, and I think there's a lot of room for improvement, and we would happily like to hear the feedback from all of you on how we can further in the future use this tool to develop medical education, clinical reasoning, and ultimately patient care.
No, this is just unbelievable. I can't wait for Huting to summarize the journey through this case. This case is inherently so interesting. Just forget the exercise of discussing it. The idea that like somebody can be devastated by something like this and finally just melt away with prednisone is very, very cool. And I find myself really inclined to study the world of neutrophilic inflammation plus autoimmune disease more closely. And I think that's such an unusual space that we enter in. and very, very excited to dissect that more closely. But Yu-Ting, take us away.
Hi everyone. I think for this session I was more paying attention about how Dr. Ravi and ChatGPT were thinking, and it's so interesting to see that in the end, nothing like a human clinical reasoning. I don't know. I enjoy so much the clinical reasoning from Dr. Ravi. And from a teaching point, so we started with a 37 years old female with rash, red-eyed, and general severe myalgia. So at this point, Dr. Ravi mentioned the sign of general inflammation, which is fever, rash, myalgia, red eyes. Red eyes, we need to divide into superficial, the classification superficial or deep layer. And if the person or lack of discharge, for example, in this case, there was no discharge, so we think about maybe a problem with the uvea or cornea or sclera. So Dr. Ravi also mentioned about scleritis, which is involved headache and periorbital pain, and uveitis, which is photophobia and periorbital pain. At this point, also, we mentioned the possibility of the octoneuritis, which is associated with pain with eye movement, and uveitis is actually the most painful cause. So also we talk about the rash, and here it's important to know what are the alarm symptoms, is it present or not, and it's important to differentiate the characteristic of the rash, if it's papular, vesicular, purpura, etc. And here actually ChatGPT anchor into like the vesicular causes. And then one of the differential diagnosis for GPT was BCG, varicella zoster, and dengue, HSV keratitis, and toxic shock syndrome. At this point, ChatGPT was more anchoring about the infection causes or viral causes. And Dr. Ravi, at this point, he was already thinking about the possibility of autoimmune causes. And then along the other aliquot, we added to the sore throat syndrome, which is make us think about the possibility of the group A, strep-related toxic shock syndrome. And now we are thinking more about the autoimmune causes because the time of the presentation and the presence of the arthritis and the eye involvement. So, and then ChatGPT still was anchoring about the possibility of infectious diseases, but now it added the presence of the rheumatic fever as well as also think about like a strep infection. And so at this point for ChatGPT, to reach the final diagnosis, it looked like the diagnostic test needed are CBC, rheumatic factor, ANA, PCR for varicella zoster, and throat swab for group A streptococcus, and also EKG. So, but after the physical examination, additional tests were included, such as skin biopsy, ophthalmology consult, and also antistreptolysin O titer for GPT. And at this point, after the physical exam, and for Dr. Ravi, I think he mentioned that he was more focused in eye versus the GPT was more focused about rash. And also Dr. Ravi mentioned the neutrophilic leukocytosis, some of the cause would be infections such as toxic syndrome. COVID, we will need to think about, or autoimmune causes such as Still's disease. Here, there's a present polyarthritis, pharyngitis, maculopapular rash, but does not involve eye in this case. Also Kawasaki, because we have mucocutaneous symptoms. And other causes for neutrophilic dermatosis, Dr. Rabih mentioned the pyoderma gangrenosum and also the Sweet syndrome. So here, it's just very interesting to see how they were both reaching the diagnosis. And GPT, after knowing the lab result, now he's thinking more about the systemic inflammatory response syndrome, a typical presentation of BCV, rheumatic fever, and lupus. So here, GPT wanted to know more about the blood culture, PCR or VCV, EKG, and also consult with ID and rheumatology. So the final diagnosis for GPT, it was post-streptococcal reactive arthritis, and the justification for GPT was the elevated anti-streptococcal anti-streptolysine O, negative serology for infectious causes, and the physical exam findings, which Dr. Rabih also agreed with the diagnosis, and he mentioned the differential between like the post-streptococcal reactive arthritis versus rheumatic fever is the presence or the lack of the visual findings. So the final diagnosis, the Sweet syndrome, here's the presence of fever, skin lesions, and a biopsy with the neutrophilic infiltration with the vasculitis. So I think in summary, this is a really good learning lesson, and using GPT as a tool for the differential diagnosis and the management, I think should be the one of the great way to help all the next generation of clinical reasoners. Thank you so much.
That was amazing. I can't believe you captured all that, the compare, contrast, the learning, the setup. That was so good. Thank you again, Hu-Ting, for the teaching points, and Ricardo for bearing with us as we stole your screen, give it back to you, stole your screen, give it back to you. A huge thank you to Francisco and Ravi. This is probably, we're going to look back on this day as having started something new and special, I think, within CP Solvers. We're very, very grateful to you all. And yeah, I have a lot to learn. I think when you said, Hu-Ting, that ChatGPT was leaning on the skin and I was leaning on the eyes, and ChatGPT ultimately turned out to be using the right problem to focusing on the skin. That's a big lesson for me to tackle my fears of dermatology, which I will spend most of this weekend doing. So I appreciate that nudge. I think at the end of the day, I have two take homes. One is, Reza, where are you? Wake up. And the other is that in the battle of human versus machine, dermatology naturally wins. So congrats, congrats to dermatology. Any final reflections, Francisco or Ravi, before we go?
It was a true pleasure. I hope we really can move ahead with this concept, and yeah, we appreciate all the help, Ravi, all the team, all the people that attended. Yeah, feel free to share your ideas. We'd love to hear them.
All right, everyone. See you next time. Bye.